All right, so welcome back to another lecture, a One Peak lecture. I'm doing this particular lecture on menopause. And I'm going to call this a bit of a dense lecture because there's so much information to give to you about women. I always say women are not complicated. Please try not to ever use that term to describe women. I think women are dynamic. And most of our practitioners, after they start really learning about how to optimize a woman's hormones and optimize a man's hormones, they often say one thing: I just want to see men because it's just so much easier than women. Women are so complicated. But I like to look at it like, women are dynamic, and there's just a lot of different things to take into consideration, not to mention the controversy over women's hormone optimization, treating women with hormones, and just the ongoing controversy, and the pendulum continues to swing from one end to the other about whether we should even be using hormones to treat women as they age. So obviously I'm a huge proponent of it. I've been doing it 30 years. I have many patients, including my parents, family members that have been optimized for up to 30 years and really don't look anything like their counterparts, meaning they don't have medical issues, they're on no medication, their entire exterior of their body looks like they have not aged. I'm not exaggerating here. And just how when you compare them, an 80-year-old that's been a hormone optimized for 30 years versus an 80-year-old who hasn't, it's not just about vanity, it's about really how their whole body and system has aged. It's completely different. And it's just a really cool thing to have been in this type of medicine for so many years and really see it evolve in such a wonderful way. So this particular lecture is going to give you sort of the nuts and bolts on menopausal women. What does the research say about what's going on with hormone therapy, and then a case study on treating a woman that's in menopause and how her life turned around. But to really dig into the research, I'm going to have a separate lecture for you that addresses the very detailed parts of research that dates back even 40 years and what it says about the protection to the bones, brain, heart, colon as a woman ages. So this is going to be the non-scientific lecture, although there will be the Women's Health Initiative study presented in this lecture. So where are we at today? I think it's important to actually talk about just where we're at today with our health globally. I think that this is the reason why we do what we do at One Peak Medical, is to take people that are having all of these issues as they age and move them onto a different health path, move them from a sick path to a health path. So I think these are important stats to go over where we're at today globally, because it's not just affecting people in the US, it's affecting people all over the world. And just to remember, this is why we do what we do. So the epidemic of diseases today includes depression, obesity, heart disease, inflammation, dementia, immunity, autoimmune disorders, diabetes, and ADD. There's also things we could throw in: chronic pain and lots of other issues. I include ADD in this list because the prescriptions for ADD are definitely on the rise. It's really kind of unbelievable to me how many people come in thinking they have ADD in the world that we live in. It's no wonder that they feel like they have it with the sensory input that they have every day, just causing a brain scramble. Depression affects 264 million people globally. Worldwide obesity has tripled since 1975. There are more than 1.9 billion adults that are overweight. Of these, 650 million are considered obese. Most of the world's population live in countries where obesity kills more people than people who are underweight, which is pretty crazy when you think about it. You think, wow, obesity is actually now has passed the number of people that are dying from being underweight and in famine areas. 38 million children under the age of 5 were overweight or obese in 2019. We've never seen that before. That's something that's just awful. Obesity is preventable, and that's what we're all about at One Peak Medical. We have a really strong division in our office, really working at trying to get the patient on a better nutritional plan, fitness plan, and correcting some of those habits that really have led them to the obesity state. Diabetes is one of the leading causes of death in the world. 422 million people worldwide have diabetes. 1.6 million deaths are directly attributed to diabetes every single year. These statistics are very interesting to me. Dementia affects 50 million people. And of the 50 million people that have dementia, 10 million new cases are discovered every year. Alzheimer's disease is the most common cause of dementia, about 60 to 70% of the cases. And I'm laying this groundwork for you because hormone therapy has a lot to do with preventing all of these things that we're talking about. So it's not just that everything is so grim in our world, it's about we have the ability as healthcare practitioners to really affect a person's health and to protect them from these things. Or if they're going down this path and already are symptomatic and have some of these things, getting them off that path and reversing it. Cardiovascular diseases are the #1 cause of death globally for men and women. More people die annually from cardiovascular diseases than any other cause. An estimated 20 million people die from cardiovascular diseases, representing 31% of all the global deaths, and nearly half of these people are women. So women, it's interesting when you look at hormone therapy and its protection for the heart, there's so much misinformation out there. It's the #1 killer of women, far more than from death of breast cancer. But again, it seems that women are often just focused on breast cancer as it pertains to hormone therapy. Around 1/3 of the deaths from cancer are due to the 5 leading behavioral and dietary risk factors. This is very important to know as it pertains to One Peak Medical. High body mass index, body fat index, low fruit and vegetable intake, lack of physical activity, tobacco use, and excessive alcohol use really are the factors that we should be focusing on as healthcare providers. Cancer-causing infections such as hepatitis and human papillomavirus, HPV, are responsible for up to 25% of the cancer cases. This is also really important because HPV is very much tied to the immune system, and that's really what we're all about, is protecting people's immune system as they age. Stress and other stress-related illnesses, 70 to 80% of all illnesses are attributed to stress. That's another area that we work on, especially for women in our office, is it's teaching them how to manage stress better, but also equipping their body and their endocrine system to be able to manage stress better. So this is just an example of how hormones go down with age. I've showed this slide to you before in a previous lecture, but you can see by age 30, the hormones are starting to decline. Now, this is the average woman. If you take somebody who's more stressed, has poor lifestyle habits, not sleeping at night, having a high sugar, high flour, high glycemic diet, if you add, and some genetic issues, if you add that to this, you'll see a more sharp decline here, especially in the area of progesterone with stress. This is such a great slide. I actually used this slide, made this slide for my book, Brilliant Burnout, the last book I wrote. I really wanted to give people a visual of how hormones affect every area of the body. The hormones interact with neurobrain chemicals, which is really important to know. We're not separate system people. Women are definitely not separate system people. We need to understand how all of our systems interrelate with each other. And the more that we understand that, the more that we can positively affect our patients. So menopause is actually defined as 12 consecutive months with no periods. That's the official definition of menopause. Most patients will ask you, most women at some point will ask you, when am I going to be through menopause? And, because it's like they think that they just need to get through it and all of a sudden they won't have any symptoms anymore. And I'm sorry to tell you that you're going to have to tell your patients you will never get through menopause. Once you're in menopause, you're in menopause. That's it. you're in a hormone deficiency state. The eggs have run out. There's no production of hormones, very little production of hormones from the ovaries in menopause, still some, but very little. And also the backup glands for the ovaries, when the ovaries fail, it's called ovarian failure. Menopause is ovarian failure. The backup glands for the ovaries are the adrenal glands, the stress glands. So the adrenals make the same hormones as the ovaries, but in smaller quantities. But the problem is, and I get this question asked from women all the time, is why doesn't my body, if I was meant to have hormones long term, why wouldn't I just have them? Why do I have to take something if my body, it's not natural to my body? And I always explain to women, well, nothing about menopause today and nothing about your stress glands is natural. We don't live in any kind of a natural state in this world. We live in a very toxic environment. Our lifestyles are mostly toxic. We burn out our adrenal glands, our stress glands, before we even get to menopause, so we have no backup. If we lived in a perfect world where we ate well, we took care of ourselves, we managed our stress, we got to bed when the sun went down, all of those things that we used to do many, many years ago, we would be in a different place than we are today. But now we live half of our lives in menopause. The average lifespan of the female, we live half of our lives in a hormone deficiency state. And we can't do that well without any disease setting in or disorder setting in if we have zero hormones being produced from alternate glands like the adrenals. So that's the crux of the problem today, is that we're living half of our life in a hormone void state, and our lifestyle is not such that it supports hormone production naturally. The average age of menopause is 51.4. Women in these ages between 45 and 55 can have periods, 2 times a year, 1 time a year, 6 times a year. It definitely waxes and wanes until it gets to the point of true ovarian failure, with the FSH going up and the production of estrogen and progesterone going down. 75 to 85% of women experience hot flashes and night sweats. So the vast majority of women experience this, and it will experience it the entire time that they're menopausal. So while it might get better if you did not intervene with hormones, it might get better with time. But even until they take their last breath, most women have some hot flash or night sweat still occurring even into their 80s if they're not treated hormonally. 50 to 75% of women will see a decline in sexual function, drive, and symptoms preventing healthy sex if untreated. Age-related illnesses, osteoarthritis, diabetes, hypertension, obesity, osteoporosis, hearing loss, vision problems, dementia, cognitive decline, stress disorders, bladder problems, colon cancer, breast cancer, uterine cancer, rectal cancer, depression, body pain, and autoimmune disorders. These are all disorders that occur from a connection to hormone decline. So we don't see these issues in younger women. This is a hormone decline group of disorders. So why are women even seeking out hormone therapy? Why are they coming into the office? Why do they come into our office and say, I need help? What are the main reasons? Because I think some women and some medical professionals feel like, well, we don't just treat hot flashes and night sweats. So if you're not having hot flashes and night sweats, you probably don't need hormone therapy. Most medical professionals have not connected the dots of exactly what is happening to that woman in perimenopause or menopause that should be treated. And these are the reasons. Women do not want to be depressed. They might want to treat their hormone deficiency to see if it helps their depression so they don't have to go on an antidepressant. They want a better sex drive. They want to not have pain when they're having sex. They want to sleep better, more energy during the day instead of hitting the wall at 2 o'clock in the afternoon. Better glucose balance to help offset diabetes. We know that HRT, or hormone therapy or hormone optimization, protects against diabetes. Vasomotor control, less hot flashes, night sweats. Like I said, well into the 70s without hormone therapy, women will experience this. Anti-aging for the skin, they want to have less wrinkling. They want to keep the elasticity in their skin. They don't want to have excessive bruising and friability of their skin. less body and joint pain, better endurance, stress, and vitality, keeping their vigor for life and their excitement for their life, sleep regeneration, and achieving restorative sleep, not just 8 hours of sleep, but good restorative sleep. Brain function, memory, focus, and concentration. This is one of the main reasons women come in and just saying, you know, I think I'm losing my mind, or I think I have dementia, and really what they need is they just need to have hormone optimization. So these are just, I thought I would include this. It's kind of small print, but you have the PowerPoint. These are just some success stories. I've just picked a few to share with you over the years, and I'll go through them because I think they're pretty profound. And they're not unusual either. These are very common stories that we hear in the office every single day. A 55-year-old woman with a 5-year treatment regime, seeing multiple rheumatologists for fibromyalgia. I used to always tell patients fibromyalgia is fibromyalgia. It's just a name, right? It is a diagnosis and it is a name. But fibromyalgia in my definition is just hormone deficiencies in multiple systems, in multiple organs. So when you fix the hormone deficiencies, these women get better. She was not on hormone therapy. She was menopausal. She was taking pain medications, anti-inflammatories, antidepressants, insomnia drugs, and high blood pressure meds. She had been 2 years with no periods, pain keeping her from enjoying life, keeping a job. She could not, her memory and focus was not good. She had very unstable moods. She started hormones and thyroid therapy because her levels showed that she needed it. And in 8 months, she had lost 30 pounds. She was sleeping through the night. She was off every single medication. She had very little body pain. She got a new job. Her relationship with her partner was starting to mend. She felt better about herself and her life, and she rerouted her entire future onto a happy and healthy path. I mean, imagine you're 55 and you were in that state like I described in that first sentence up there. I mean, where do you go from there if you're 55? You've got another 30 years to live. Are you going to live like that, or are you going to correct the deficiencies so that you can get on a completely different path? 48-year-old with extreme night sweats. She wasn't sleeping, depressed, irritable, had poor memory and concentration, and no sex drive. She came to us with missing periods over the last year. Her FSH, which is the follicle stimulating hormone telling us if you're going into menopause, it was sort of borderline normal. No other labs had been drawn by her primary care provider. She just had seen her primary care provider, and he says, hey, you're not in menopause. Your FSH is equivocal, so we're not going to treat you, so we'll just see you back. And you just watch your symptoms. So the labs, when we drew them, revealed that she actually did have menopausal levels of estrogen, progesterone, testosterone, DHEA, low active thyroid, which is T3. And we explained to her that an FSH fluctuates. It's a signal hormone. So it might be up one day and down the next. And if you happen to go into the medical office and the only test they're running is an FSH, it's not going to show you the whole picture. When we ordered all the tests that we actually needed to order, we found out that she was very deficient. She started on the hormone optimization plan and the fitness nutritional plan, and in 6 weeks, every single symptom was gone. She really has never stopped sending patients our way because it completely changed her life. Lastly, a 60-year-old female executive, large Fortune 500 company I had the privilege to treat. She had been in menopause. She had stopped due to her doc telling her it was time to stop her hormones. She had been on hormone therapy. She had been on it for a couple of years. And her doctor, 3 or 4 years, her doctor said, you know what, you've been on it long enough, you need to stop hormone therapy. And this is very common that we hear this because hormone therapy should be used for the least amount of time to help the majority of side effects that you have with menopause. And if you have side effects with menopause, you still need to be on the smallest dose for the least amount of time, is what the standard line is from primary care providers. When she stopped her hormones, she then needed to start Ambien, Zoloft, Xanax, and Adderall, as she had insomnia, depression, anxiety, and now adult ADD. And isn't it interesting? She didn't have any of these problems before. She was perfectly fine. So we've exchanged hormone therapy because it's just time to stop hormone therapy. And we've given her a whole set of new problems that she now needs to take drugs for that have all sorts of side effects. It really, when you step back and you look at this, it makes no sense. She had none of these problems prior. The testing revealed low levels of all hormones, including her stress glands, cortisol, and thyroid. She started on hormone therapy, and in 3 months, all of her symptoms were gone, and she successfully weaned off all of her other medications and continued to take hormone therapy. Again, these are not unusual stories. This is what keeps our practitioners at One Peak Medical wanting to stay here, because they finally figured out how to give their patients something that turns their health and life around, and it's very rewarding. So these are the symptoms, and I won't go through every single one of them. You have the PowerPoint, but it's really important to know that estrogen and hormone deficiency is not just about hot flashes and night sweats. It's about all of these symptoms, and it's about all of these problems that can occur. And many times we don't relate these symptoms in general practices back to hormone therapy, and it's very important that we understand how much it affects the entire body. This one right here, ants crawling on your skin. I've actually had patients come in and crying and telling me it just feels like my whole body is itching, like I have ants crawling on my skin, and it's very disturbing at night to be in bed and feel like there's something crawling on your skin. You have hormone receptors in your skin. This is not an uncommon side effect, but I will tell you there's been many, many women that have come into me as patients that have told these symptoms to their medical professionals that they've seen and tried to get help, and the medical professionals had no idea it was related to hormones, would never say it was related to hormones, sent her to a dermatologist didn't know, and they really think that they're losing their mind. Some patients even treated with antipsychotics for this problem when they really should have just been tested for hormone deficiencies. So these are the symptoms that we assess for. Again, it's the very same as perimenopause, PCOS, PMS. We want to know the severity and the type of side effect or symptom that they're having. So this is the form, one of the forms we use. We also want to know this personal risk history. This is very important. We want to know what their breast cancer history and family history is. Have they had it themselves? Are they at high risk? Uterine cancer, previous cardiac events, metabolic history, family history, because we're trying to determine how much of a risk factors this particular woman has and why she may need hormone therapy, and then what type. So these are the labs that we would order for a menopausal woman. Really, these are the same labs that we would order for any woman. But again, this is what we're looking at. We're looking at the sex hormones, the ovarian hormones, the stress gland, adrenal hormones, the thyroid hormones, the vitamin levels, particularly vitamin D and B12. We can order other ones, but these are the main ones we ordered in the first screening. And then general labs include these. We want to know what's happening with the whole system, not just the sex hormones. These are alternative labs that we can order if there's other issues going on, or we might choose to order these later. So the first visit of a menopausal woman, we're gonna do a very detailed history. We want to know exactly how she's feeling. We want to know those symptoms and how bad they are and what she's done to try to correct them. This is all part of the history that we have to put in the subjective part of the chart. We want to know, we have great handouts in our office and laminated forms that list every single hormone and what every hormone is responsible for. And I like to just flip that right to the patient and say, do you have any of these symptoms? Because that's how you create your subjective history in the chart. You want to know what's going on with that patient. And I think I'm just going to stop for a second and go back and say, I think it's a little bit of a mind twist for a lot of medical providers that come to work for One Peak, because they're so used to, okay, tell me about your diabetes, tell me about your high blood pressure, tell me about, the medication you're on, tell me about this. And so we're just like collecting data. But this is a different way of doing it. It's actually looking at their symptoms and looking at their history, but saying that, why do they have this? And what can we order to figure out why they have this problem? Why does a 48-year-old woman have high blood pressure? Is it that she's just overweight? What if she's not overweight? Why does she have high blood pressure? And you will begin to start saying it's because of A, B, and C that she's actually deficient in. And then we can go back and treat it rather than just chasing symptoms like blood pressure, problems with concentration, sleep. Instead of chasing symptoms and treating them, we actually order the test, figure out where they are, and then treat the underlying deficiency. We want to know, what is their diet? Is it high sugar, high flour? Do we need to get them into our fitness nutritional educators to try to figure out how to get them back on track and what plan they should be on? How much are they moving their body? What's their stress level? How do they even deal with their stress? What are their current medications and supplements? And then we want to explain the triad of hormones. That this is what we do different at One Peak. We look at the adrenals, the sex hormones, and also the thyroid hormones, and then look at the diet, the gut balance, and the brain chemicals. I like to give handouts at the first visit, so when I train medical providers, we have handouts in each of our exam rooms, and just pulling out a couple of handouts that are relevant to that patient. It might just be, what hormones are we testing and what do they do? And giving them a couple of handouts and then scheduling them with our fitness nutritional consultant educators that are in our office. That is a visit that actually can be billed to insurance because you see the patient with the fitness nutritional consultant. And it's just so important to just start drilling into your head that 50% of your success with patients is going to be because they're eating better. So that's really important to get some help and let our fitness nutritional educators help you educate your patients. Scheduling a yearly exam. All patients get a gynecological exam every year. Men get a physical exam once a year. That's really important. If 25% of all cancers diagnosed are HPV, why are we not putting our hands on our female patients? That's a good question to ask yourself. Even though a lot of the organizations now are saying you only need to have a physical exam, gynecological exam every 3 years. If you're in a mutual monogamous relationship, and you're not at high risk. We don't listen to that. We do an exam every year. Nearly every insurance company covers it, and it's just a really good way to make sure everything is good as they age. Who should not use hormone replacement therapy? If you have a personal recent history of breast cancer or ovarian cancer, unless the quality of life is so poor that they're willing to assume the risks, this is another conversation that we'll have in training, or they're at least 1 to 5 years out from the treatment of their cancer and they're in remission, and or their oncologist agrees that their quality of life is so poor that they really need to be on something. And there's some really interesting ways that we can treat patients that really do not load them up with a lot of estrogen. If they have a personal history of certain endometrial cancers, actually most endometrial cancers you can treat with hormone therapy as long as it's been treated, uterus has been removed, nodes are negative. It's not an absolute contraindication to hormone therapy, and we work really closely with oncologists on that too. If they have a personal history of pulmonary embolism, deep vein thrombosis, heart attack, or stroke that's recent and unstable, we would not use oral medication. We would only use transdermal medication. We will get into that later. If they have vaginal bleeding from an unknown cause, obviously we would want to work the patient up first before we gave them hormone therapy. If they have active liver disease, we would not use any hormones that make the first pass to the liver, so we would avoid oral estrogen and oral hormone therapy. The advantages of bioidentical hormones. This is something that a lot of people are confused about. Hormones are called bioidentical or natural if there are exact duplicates of what the body makes. So we have pharmaceutical hormones, hormones that you can get at any commercial pharmacy that are considered bioidentical. And I'm telling you right now, nearly every medical provider that has an opinion about bioidentical hormones, they don't know what they're saying. And I can only say that because I've heard this for 30 years now. Bioidentical hormones can be commercially manufactured, but they're a synthetic hormone, which is okay. So if you take a hormone like estradiol, estradiol that's in a pill form or in a patch form that you can write a prescription for your patients at any pharmacy, commercial pharmacy, is bioidentical. If you put that estradiol molecule up to the body's molecule of estrogen, they're identical. But it's not, it doesn't come from a plant, it comes from a, it's a synthetic. So it's a synthetic version of it, but it doesn't necessarily mean it's bad. So the advantages of bioidenticals is that they're the same molecular structure. The dosing is done according to the blood tests. It has minimal side effects with no interactions with drugs or allergic reactions. I guess the only disadvantage would be if you were using a compounding hormone, compounding pharmacy to treat your patients on HRT. You know, if you didn't understand dosing and you used excessive doses, you would probably get side effects. So obviously we train you in that area so that doesn't happen. But there is an advantage of using a bioidentical hormone because it does match the molecular structure of the body. And if you have a choice to use that, the body understands something that's identical more than something that's not identical. So just to further explain bioidentical hormones, because this is a source of confusion for most people new to hormone optimization field. Why are they safer than synthetic hormones? And this is a slippery slope. I don't necessarily make announcements to patients that bioidentical hormones are safer. I just simply explain this in this way to patients, that hormones do very complex and specific jobs in the body by fitting into parts of your cells called receptors, much of the same way that a key fits into the lock. Once the hormone is actually in the receptor, it gives the cell instructions. If the molecular structure of the hormone is different, so it's not bioidentical, the instructions given to that cell are actually different. So bioidentical hormone instructions have evolved within the human body for thousands of years. So the body knows how to use those instructions and how to safely dispose of them. So when you introduce something that's not bioidentical, it may fit in the keyhole, but the instructions will be slightly different. And all I tell patients is that if you have the choice to have a lock and key that are a perfect match and something that the body recognizes that is known to the human body, why would we not choose that one? So bioidentical human estrogens, there's 3 of them. Estradiol, that's called E2. Estrone is called E1. Estriol, the weakest estrogen, is called E3. The most common estrogen used in hormone therapy is estradiol. So you'll see that on the blood tests when we order blood tests for patients. We don't order estrone and estriol, although you could. And there may be a place for that we'll talk about later, but this is the main hormone that we use for replacement and that we're testing in women. Bioidentical progesterone is simply called by its own name, which is progesterone. The structural name is P4. So many times on your lab review sheets when I'm training you, I'll refer to progesterone as P4 because it's shorter to write, and also E2 for estradiol. Bioidentical testosterone is simply called by its own name, testosterone or testosterone USP. The original source of bioidentical hormones comes from a plant, which is yams. Yams and soy both contain abundant hormone-like structures that do not have any activity in the humans. What starts out as a wild yam gets converted through 4 enzymatic steps in the laboratory before it ends up as a bioidentical hormone, exactly equal to what the body produces. So, you know, when you look back on the origination, the pharmaceutical origination of drugs, most of our drugs used to come from plants because you can derive the molecular structure from certain plants. And a lot of our supplements today come from plants. But as things evolved over time and the pharmaceutical industry picked up, many of our what used to be source was plants now are synthetic chemicals. A compounding pharmacy, this is important to know, a compounding pharmacy is actually just a regular pharmacy that a pharmacist within that pharmacy has decided, I want to become an expert in compounding hormones. Compounded hormones are just basically FDA-approved substances like estradiol, micronized progesterone, and testosterone. These are FDA-approved substances that actually are brought to the pharmacy, and the pharmacy mixes them up according to what the patient needs. So they can choose between creams. They can choose to, I think I have a list of them here. They can choose from creams, topical creams that absorb very well through the skin, sublingual troches, vaginal inserts, tablets, capsules. So the nice thing about it is you can custom make the hormones for the patient. And a lot of patients really like the idea that it's plant-based and really like the idea that we can change it according to what they need and how they're absorbing it. Specifically on estrogen, I just want to go over, there's 150 to 200 effects of estrogen in the body. These are just some of them. Again, it's important to learn these over time. You should be able to, within 6 months of starting at One Peak, you should be able to just say this. You should be able to tell a patient, this is what estrogen does. It does all of these things. And it will make you a better practitioner the more that you understand that this is what estrogen, the effects of estrogen on the body. If a woman has estrogen deficiency symptoms, these are some of the symptoms that they will have that they often come into the office and complain about. I just want to bring your attention to, there's a lot of different types, many different types of estrogens. So we have estrogens that are in birth control pills, and many of them are listed here. Then we have estrogens that are used in hormone replacement therapy. And so this is a mixture of hormone replacement therapy. So when you see the word estradiol, Climera is an estrogen patch. When you see estradiol, that means it's bioidentical. It's the same molecular structure as what your body produces. There is no birth control pill that has estradiol in it. All birth control pills are synthetic, non-bioidentical estrogens. So, you would actually see, let's see, it'll probably be on the next page. Like Ogen is a good example. These are non-synthetic, non-bioidentical estrogens. So we really are interested in hormone replacement therapy in using bioidentical, the same molecular structures what the body produces, estrogens. And those are only described as estradiol. So if you're prescribing someone that's not estradiol, then it's not bioidentical and it's certainly not plant-based. These are the effects of progesterone on the body. When a woman has lack of progesterone, these are really important to understand and treat your patients. If you had one hormone to use and you only had one hormone to use for the entire lifespan of the female, this is the one that you want. Because progesterone is higher up on the hormone chain, it actually precurses estrogen and precurses testosterone. It is the #1 supporting hormone to the thyroid and the #1 supporting hormone to the adrenal stress gland. So this is your answer. But I don't believe in just treating with one hormone. I think the balance is so important for patients. I was just talking to a patient the other day who has polycystic ovarian syndrome. And you've already heard my lecture on PCOS. The main hormone deficiency issue, there's many in PCOS, but the main one is lack of progesterone. So we want to replace progesterone because it is fundamental for the woman to get better. But these are the reasons why. Progesterone is a very calming hormone for the female system. The progesterone, this slide just talks about as women get closer to menopause, and their menopausal or perimenopausal symptoms can start 15 years before they stop having periods. But the main hormone that you're going to see a decline in, especially today, is progesterone. Progesterone drops sharply with stress because stress impedes or interferes with ovulation. And if you're not ovulating, you're not making progesterone. You can still have regular periods and not ovulate. You might not ovulate for 12 months straight, but you might have 12 regular periods. So that's kind of confusing for most people. They think, oh, if I'm not ovulating, then I'm not going to have a regular period. That's not true. you will still have periods, but your periods will probably be heavier. You're going to be at more risk for endometriosis because you don't have any progesterone to calm things down because you're not ovulating. These are the effects of progesterone on the body. It's really important to memorize these, especially in the first parts of starting at one peak, because you want to at some point be able to just to reel these off without having to look at a piece of paper. And you have to know these things because if you're trying to keep your patient on a wellness path, it's really important that it even helps prevent autoimmune disorders. If progesterone is the #1 hormone to the immune system and to the adrenals, which is your immune system, if progesterone is the #1 supporting hormone to that, why would we not be treating patients that have autoimmune disorders with progesterone? So these are the things you have to learn over time, and it comes to you. The more you say it with patients, the more you learn it. So this is something that is also very important to understand because our medical community and the scientific information that's out there does not get this right. This is basic 101. And I don't know why I hear this. I mean, I read articles all the time. I listen to OBGYNs talk. I listen to oncologists and family practitioners talk, and they don't get this right. This is very, very straightforward. A progestin mimics the action of progesterone. So remember the lock and key. Progesterone fits the lock and key. It is what the body produces. Progestin fits, but not quite the same. Progestins are given to PCOS women in order to induce a period, or if a woman has postmenopausal bleeding, they would give them a progestin. This is a practice that's been going on for 50 years. Synthetic progestins versus progesterones were developed with the advent of the birth control pills. And the reason why is the half-life, the time that it takes the compound once it hits your body to reach 50% level is considered the half-life. The synthetic progestins were created because they needed a longer half-life of progesterone because progesterone has a short half-life. Not a big deal. We can deal with a short half-life. But that's how researchers began looking at the creation of progestins. They wanted something that lasted longer to use for birth control pills. Since progestins are 10 to 100 times as potent and they have a longer half-life in the body than progesterone does, they chose that along with synthetic estrogen to use in the birth control pills. Again, none of this is really important to you except for it's important to understand that when we're using birth control pills, we still want to replace with natural progesterone to protect the woman because synthetic progestins leach progesterone from the female body. It's taking away a hormone that's very important. You saw all the benefits of progesterone. When you give a woman birth control pills, it's taking that progesterone away from her, so we want to replace it. Synthetic progestins are literally analogs of progesterone, natural occurring progesterone in the body. In other words, they are lookalikes that have some similarities in form and function to true progesterone, but they're not exactly the same. However, one thing is certain, that they are not produced in the human body. Progestins are not produced in the human body. And while I say it's important that you get this in your head, medical professionals and researchers interchange the words. When they say progestins, they will often say progesterone. When they say a woman should not have progesterone, and then they actually write MPA. MPA, medroxyprogesterone acetate, which is a progestin, they use that word and progesterone as if they're the same, and they're not the same at all. These are the different progestins and progesterones. Progesterone is natural occurring, plant-based. For many, many years could not be patented because it's a plant-based hormone. So pharmaceutical companies came up with generic, synthetic forms of progestins, but they're used in all types of birth control pills, IUDs. They're used as oral medication for excessive bleeding. They're used in hormone replacement therapy. So unless you actually see, just like estradiol, you have to see progesterone. Anything other than actual progesterone is a synthetic non-bioidentical. We're not interested in it. Unless it's in the birth control pill or the Mirena is levonorgestrel. And we would still give them progesterone to help replace. So hopefully that makes sense to you, but this is very confusing when you look things up and you don't know what's what. All you need to know, there's a difference between progesterone and basically everything else. These are more birth control pill types of norethindrone acetate. Drospirenone is a synthetic type of progestin also. Medroxyprogesterone acetate, the Depo-Provera shot. So there's many of them now. So here's the chemical structure, just shows you, kind of drives the point home. These two should not be used interchangeably. These two are not the same as bioidentical plant-based or human progesterone. They're completely different. The whole molecular structure is different. And we should not say that they're the same. It would be like saying Tylenol and aspirin are the same. They're not the same. Changes in the molecular configuration of a chemical compound, such as the differences between progestins and progesterones, can have drastic differences in the body. While hormone replacement therapy with progesterone causes little or any negative effects and has not been shown in any scientific study, any research study to have these problems, we have many scientific research studies, very good studies, that show that progestins cause all of these problems. So why do we say they're the same? When in research, they've never been able to show that they have the same side effects or the same outcomes. So I just want to talk now, this is the dense part of this lecture. I just want to talk right now about menopause, women, and hormones as it pertains to the Women's Health Initiative study. Some of you newer practitioners or younger practitioners that are coming to work for One Peak, not old like me, the Women's Health Initiative study really derailed women's thinking and physicians' prescribing of hormones. This was a 2001 study. It was a nightmare study. I'm going to tell you in a second why it was a nightmare study. There's been years and thousands of studies that have shown that hormone replacement therapy benefits the heart, benefits the brain, benefits the bone, reduces colon cancer, reduces side effects of menopause. Hundreds and thousands of studies that we have that show that. Then we had the advent of the Women's Health Initiative study. This was a study, and I'm sure you hear about it, because this is really what we're still talking about today when we're tentative about prescribing hormone therapy. Everybody remembers this study that just will not stop rearing its ugly head. Between 1993 and 1998, 160,000 healthy postmenopausal women ages 50 to 79 were enrolled in this particular study. This was a Wyeth-Ayerst study. Wyeth-Ayerst was the pharmaceutical company at the time that produced a hormone an estrogen called Premarin, which is kind of known as the horse estrogen, and also Provera, which is medroxyprogesterone acetate, and they had a combo drug called Prempro. The study was designed, it was a long-term study to really look at the effects of postmenopausal hormone therapy on heart disease, osteoporosis, colorectal cancer, and breast cancer, and the risk thereof. Wyeth-Ayerst was very cocky about this study. They thought for sure they were going to nail it because we had so much other research that showed that HRT was beneficial, hormone optimization was beneficial for these areas, but they wanted their particular drug, Prempro, to also show these benefits. So one arm of the study looked at the effects of estrogen plus progestin, not progesterone, chemically altered from progesterone. That was called Prempro. That was one arm of the study. The progestin component of Prempro acts in many ways similar to progesterone, like I've told you before, but it's chemically different. And though they differ just a little bit with a few electrons, they're connected to an oxygen atom, and that particular difference has powerful effects on the body, and that was shown in this study. The synthetic progestin, as opposed to natural bioidentical progesterone, causes the ovaries to shut down production of natural progesterone because the body is being flooded with a synthetic variant of that hormone. So women in menopause still produce some progesterone, and they can produce it from their adrenal glands too. But when you use a synthetic progestin, it shuts the body's production of its own progesterone down. This happens in younger women too. The other arm of the study that was women that had undergone a hysterectomy, and they were only given Premarin, not progestin, just Premarin. In each arm of the trial, half of the women were randomly chosen to receive hormone pills, and the other half was chosen to receive placebos. And they, of course, were both blinded to this. So the study was halted abruptly in July of 2002. An analysis by the DSMB discovered that women taking estrogen plus progestin combination had an increased risk of breast cancer as it compared to women taking the placebo pill. So there was a complete freak out moment. They stopped the study. They didn't know what was going on. Breast cancer rates went up. It was not statistically significant. It was borderline, but it was enough for them to stop the study. And it hit every single magazine, periodical. I mean, every single journal reported this. It was all over the world that hormone therapy should be stopped by all women. The analysis also indicated that the overall health risk of taking estrogen plus progestin outweighed the benefits. In addition to the increased cancer risk, women using the progestin, in the progestin group, also had an increased risk of heart attacks, strokes, blood clots in the lung, and blood clots in the legs. So it was pretty scary when all of this came out. Now keep in mind, we had been using hormone therapy for 50, 60, 70 years and had not seen this. So this was something that was new to everybody. So the hormone therapy that they were talking about in this study was actually Premarin plus Provera, or medroxyprogesterone acetate. That was just more information on the differences between progestin and progesterones. The study suggests that long-term use, more than 4 years, of hormone replacement therapy increases a woman's risk for heart disease and breast cancer. So this is the reason why healthcare providers still today will not prescribe hormone replacement therapy long-term, because they feel that if you prescribe HRT, it doesn't matter what it is, just any hormone, because they're lumping them all together. If you prescribe it for more than 4 years, you're putting the women at risk for breast cancer and heart disease. Which is really kind of frightening, because there really was one hormone that was the problem. The bottom line from the Women's Health Initiative study was that the following harmful effects were caused or shown to have an increased risk as a result of using HRT. The combination of estrogen with progestin, not progesterone, results in increased risk of cardiovascular disease, heart attacks, lung clots, breast cancer, stroke, blood clots. Most of these not statistically significant, I'm talking too fast, and increased risk of Alzheimer's disease, but it was still an increased risk. So that the take-home message was, you really shouldn't use hormone therapy unless you absolutely have to have it. So if you have to have it, use it in the smallest dose for the least amount of time. The benefits that they found, there were actually two benefits, or really three benefits: decreased risk of colon cancer, decreased risk of bone fractures, and of course it helped with vaginal atrophy, hot flashes, and night sweats. But interestingly enough, there was a second part of the study. That was the second arm on the study, and that was women. They were randomized to Prem-Pro, and that was one arm of the study, and the other arm was estrogen only, called Premarin. After the study was halted, a new study began to investigate the effects of just estrogen alone on women that have had a hysterectomy. The progestin, Provera, was removed from the study because they wanted to see just the effects of estrogen. And so they continued that arm of the study between 2002 until 2004. And then they released these results in 2004, and it showed that estrogen alone showed this. The second arm of the study, using estrogen alone without Provera or progestin, the results were really different. There was no increased risk of breast cancer or heart disease. In fact, there was a decreased risk of cancer and heart disease in the estrogen-only group. Interesting, huh? However, most physicians and the media have misinterpreted the data and conclude that estrogen is harmful when in fact it's not. it is progestin or Provera. When they removed that, they didn't see the problem in this particular study. So I think it's interesting and really important for you to know that this is what the Women's Health Initiative study findings were. It was a very flawed study. It was a huge overreaction. If we had a blood pressure med that caused stroke, we would not tell the entire world to stop taking all blood pressure meds. We would identify what drug was causing the problem and we would remove it. But that didn't happen here. And progestin has gone on, I'll talk about it here, to have more and more problems in other studies. And we have not addressed the fact that it is progestin that seems to be the problem. The other inappropriate conclusion was that all hormones in women should not be stopped just because Provera is harmful. The conclusion does not apply to all hormones. All hormones should not be stopped, just the Provera. What should women take in place of Provera? Well, the answer is super simple. Natural micronized progesterone. We have an alternative that's never been shown to cause these problems, and it has been studied. However, many physicians and practitioners claim that it makes no difference, that hormones are all the same. They use them interchangeably, they talk about them interchangeably, and this is simply incorrect. The natural hormone in the body is called progesterone. The synthetic chemically altered version of progesterone is called Provera or progesterone. It's completely a different molecule, and it's so important to understand that. In recent studies, Provera has been shown to cause breast cancer, but natural progesterone has never been shown to cause breast cancer. In fact, quite the contrary, micronized progesterone reduces the risk of breast cancer. Provera increases bone density, progesterone decreases bone density. Provera stimulates breast tissue. Progesterone downregulates breast receptor sites. It helps protect the breasts. Provera raises cholesterol. Progesterone lowers cholesterol. Provera or progestin is associated with multiple side effects. Progesterone really has no side effects. The only side effect progesterone has is it causes drowsiness. That's why we have you take it at night. So on and on and on. I could keep talking about this, but I think you get the point that the problem in the Women's Health Initiative study was primarily progestin. We also know that there's a problem when you use estrogen alone long term. You need the balance between the hormones. You need testosterone to protect the breasts and the brain. You need progesterone to protect the breasts and the uterus. So you have to have that good combination of hormones, not just one hormone alone. It does amaze me, things like Provera or progestins increase cholesterol and clotting, whereas progesterone actually causes the reverse of that. That actually was shown in 2002 JAMA study. And it amazes me that it still comes as a surprise in the medical community that progestins increase the risk of heart disease when it's been so well documented in the literature that progesterones don't. Provera antagonizes the beneficial effects of estrogen on coronary artery disease, and that has been shown so much in literature, but again, we don't talk about that. We just lump all the hormones together and give a black box warning to all hormone therapy. So I'm going to skip ahead. I'm just going to have you read a few of those slides there that I passed, because I want to get to the rest of this lecture here. So what do you take for hormone replacement therapy if you don't want to make the same mistakes that the Women's Health Initiative study pointed a spotlight on? The journals are very clear that the journals show a decrease when you use estradiol and progesterone, a decrease in Alzheimer's dementia by 83%, heart attacks 32%, coronary heart disease 50%. Colorectal cancer, 20%, breast cancer, neutral. Thrombosis, 8%, osteoporosis fractures, 90%. This is the stuff we should be telling our patients. When a woman comes in and wants hormone replacement therapy, you can tell her, while the jury may still be out on whether hormone therapy, estrogen and progesterone, increases your risk of breast cancer or decreases your risk, because some studies actually do show that estradiol increases your risk. It's a very small increase, but when you put it with progesterone and progesterone downregulates the breast receptor sites, there may be protection there. But do you know that you're at risk for all of these things here? This is what we should be telling our patients. This is our responsibility as healthcare providers, is to tell the patient everything. What are all of their risks? We should not just be focused on the breast. we should be telling them this. If you go half of your life without any hormones and you don't feel well, that's the reason you're here today. These are your risks without taking hormone therapy. Obviously, avoiding equine estrogens. They're very potent. There's more than 12 estrogens identified in horse estrogens, Premarin. And avoid progestins. We absolutely never use them in our office unless we're giving birth control pills, and then we add the micronized progesterone to that to protect them. The research is still real clear, and I want to make sure we don't throw everything out that we've learned from the past, that the bones, the mood, the brain, the breast, the heart, and symptom control can be controlled with hormone optimization, and it can be done safely and in a balance. You still could use the least amount possible, and that's why I love pellet therapy, because pellet therapy actually uses the lowest dose for the best effect. So I just want to give you a case study here on a woman who's 66 years old. She's 5'4", she weighs 179 pounds. I always start with that. I start with the age because I want to get an idea, are they PMSing? Are they in the perimenopause? Are they in the menopausal age? So I try to just get this visual. This woman came in with hot flashes, vaginal dryness, night sweats, low sex drive, mild depression, getting a lot of accumulation of visceral or midsection fat, painful sex, memory and concentration problems, overall loss of stamina and drive. She also had signs that were positive for osteopenia, elevated lipids, and elevated inflammatory factors. This is her history. Here she had a history of arthritis, environmental allergies, previous surgeries are here. She has, again, these are little keys to let you know what's happening with this patient. Benign fibrocystic breast changes. So she has cystic breasts. So it's telling you already she's estrogen dominant. She's taking Premarin vaginal cream, not using anything else for hormones, blood pressure meds, and an antidepressant. She was taking some supplements. This is her diet, very carbohydrate intense with very little or no protein. Exercise summary, very little exercise. Her stress level reported to be a 10. She manages her stress by praying. She's postmenopausal. She's had 6 previous pregnancies and 5 births. She has a stress level of 10 because she's running around trying to take care of a lot of her grandchildren. Her last pap smear was normal. Her last mammogram was normal. Her family history includes diabetes and heart disease. So this is kind of important too, to kind of know what the family history is. So then we get to the symptom questionnaire. It's so important to see where women are with moderate, severe, and cyclic symptoms. We wouldn't expect anything cyclic because she hasn't been bleeding, but we want to get rid of any moderate and severe symptoms. So here's her first test results. Again, just for review, this is the reference range here. This is the ideal range, and these are her test results, and this is the type of test that we ordered. So you can see her vitamin D is very low. Most people that come in that aren't taking vitamin D have very low levels. This is the optimal treatment range, the range that all the research that was done on reduction of breast cancer, heart disease, brain function, mood, immunity. Her ferritin looks pretty good at 40. We want it to be at least 40. That's the storage of iron. Her DHEA, which goes down with age, it's from the adrenal glands, it goes down with stress, and it goes down with age. She has a terrible DHEA level. She's aging rapidly just with that level being low. We actually want it to be at least 150. And then we have 2 thyroid levels, those circulating thyroid levels, T4 and T3, both of them right on the very low end of normal. And then we have the TSH, which is the thyroid stimulating hormone that comes from the brain to tell the thyroid what to do. And when I look at this, I go, whoa, she's right on the edge of hypothyroidism, right? The TSH is going up, the brain's calling for more thyroid, and the circulating T3 and T4 are suboptimal and probably dropping below normal at some time, at some points. Her progesterone level is 0.8. Sometimes we see progesterone as absolute 0, but she's almost at 0. This is the postmenopausal range. So this is the range in which we would expect somebody to be in if they're not using progesterone. If they're using progesterone, this is the treatment range. Well, obviously we wouldn't expect her to be in this range because she's not using hormones. So I would tell this woman, okay, well, you're showing up in the postmenopausal area, in the postmenopausal range, but if we treat you to get rid of your side effects and your problems, this is the safety range. This is what we want you to be at. Her FSH is elevated at 112. That's just the brain calling for more estrogen and progesterone. And the higher it is, the more symptomatic the woman is. So you can see she's way at the high end of normal on FSH. When we treat a woman when we give her estrogen and progesterone, it makes the FSH go back down again, just like a TSH. So we want it to be under 20 when we're treating them. Her estrogen level is 20. This is the range here in an untreated menopausal woman, like this person is not being treated. She's got a little bit of estrogen from the Premarin vaginal cream, but not much. When we treat patients, this is the treatment range that we want them in. This is the safety range. We don't want them to be higher and we don't want them to be lower, because when they're lower than that, especially at 20, they're not getting any benefits to their bones, brain, and heart. Lipid profile showing elevated cholesterol, elevated triglycerides. This really shows what her diet looks like. Reduced HDLs only at 20. We really want it to be greater than 60 to 90. The total glucose, the LDL, the bad cholesterol is at 190, and we want it to be less than 120 or 100. The glucose level, this tells me a lot about her diet right here. This ratio is terrible. Her insulin is elevated. We want it to be less than 8, and her glucose fasting is elevated at 113. So we know metabolically this woman is not in good shape. She also has very low testosterone. Both the free testosterone and the total is not in the optimal range. Again, once we treat her, we can get her into this range. So this really explains the story of why she's having all those symptoms. So what we did was we gave her an estradiol patch, and the reason why we picked a patch over a pill, and we will teach you this when you come to work for One Peak, is that we want her to have the hormones going through the skin. The Women's Health Initiative study and other studies have shown that if you start a woman on hormone replacement therapy that has never been on it in her 60s, late 60s and on, it may increase her risk for stroke or blood clot. So we only want to use through the skin, because the studies have been pretty clear that if you use hormones through the skin, like in a bioidentical compounded pharmacy cream, or even a sublingual lozenge, or like this, the patch, that it does not carry the same risk for stroke. In fact, it's the same as not using hormones at all. So we would start, because she's older, we'd start her on a patch, tell her to change the patch twice a week on the same days. Another option could have been estradiol 1 milligram and used it sublingually, or compounded estradiol cream. These would have been other options. I'm just telling you that so you know. And then we gave her commercialized progesterone, micronized progesterone, plant-based, from a pharmacy. Insurance covers it. 100 milligrams orally at night, because she has such a problem sleeping, and oral progesterone is very good for sleep. We gave her testosterone cream. I like to have women use testosterone cream in the labial area. Obviously, it's not a problem that men get in contact with the testosterone, because men have testosterone, so we're not worried about cross-contamination. It's super good for the vaginal tissues. It helps with atrophy, bladder infections, and it helps women with sexual function. And it's absorbed very well in the mucous membrane, so we use testosterone cream in the labial area. I also gave her estriol, which, if you remember, that was E3. That's the weakest estrogen. It's also one of the ones that's particularly good for vaginal dryness and atrophy. So I used that initially with her with a little bit more of testosterone to help take care of the vaginal atrophy, and I only did that for the first month. I gave her adrenal support supplements to help with her cortisol, to bring it up and help her get to sleep at night by doing the stress PM, turning her brain off. Thyroid support supplements, I actually chose that since she's right on the edge with her thyroid, to give her some iodine to see if her thyroid can kind of come back on its own without having to give her thyroid medicine. DHEA, that was the one hormone that was really low. Vitamin D, B complex are two vitamins that we use almost exclusively with all of our patients. We talked about diet, exercise, and stress reduction. I gave her handouts on that. I referred her to our fitness nutritional consultant, and I set her up for her yearly gynecological exam. Yes, a 66-year-old still needs an exam. And before you treat women with hormones, you better get your hands on these patients and do an exam on them, because you want to know everything is okay in the pelvic area and in the breast area for sure. I had her come back in 3 months to follow up on lab results, and she was interested in hormone pellet therapy, but I wanted her to see how she did on this first before we did the pellets, especially because of her age. So the patient comes back the second time and she says, voila, I've got no night sweats, no insomnia, irritability, dry skin, hair loss, anxiety, vaginal dryness, and her low moods are gone. She has 0 symptoms of those problems, but she still complains of occasional hot flashes, and her sex drive is a little bit less than optimal. It's better, but it's not as good as she feels like it could be. She's now able to have sex as her vaginal dryness is resolved. She's sleeping through the night, which creates better brain function during the day. She's lost 20 pounds and 10 inches of body fat. These are her second results in the green. All the green areas are showing improvement. Vitamin D, much better. Ferritin is also a little bit better. DHEA is coming up, which is great. Her thyroid is improved and much better than it was before. Her progesterone is now in the treatment range. Her FSH is much better. You can see the drop from 112 to 17.2. So now her brain's saying, oh, thank goodness this woman's got some hormones, so I can just reduce my level and my call for more hormones. Her estrogen's at 44, and you can see it's a little bit less than optimal, and she is describing more side effects of hot flashes and night sweats. Her entire lipid profile looks better, glucose and insulin much better, which is wonderful. Her diet really did change, and her free and total testosterone are better, but they could be a little bit better. So in my opinion of this result is that she could do a little bit better in estrogen, and she does have side effects of low estrogen, and a little bit better in testosterone area. So I suggested continuing on the estrogen patch and changing it twice weekly, continue the progesterone, continue the testosterone, but raise it to 8 milligrams, because we know that that will raise the testosterone, and actually some of it will go into estrogen. So I knew that I could get improvement in both areas usually if I do that. Continue the DHEA, because I knew that that would continue to support the estrogen, the vitamin D. Magnesium and curcumin were other supplements I recommended for her pain. Thyroid support, I want her to use that for 3 more months to see if I can get a little bit more improvement. I added selenium, which is a mineral for the thyroid, to her, and that did help also. And then, of course, the normal diet, exercise, and stress reduction strategies were reviewed with her also. So, third visit, 4 months later, the patient now reports improved libido, focus, concentration, and memory, even more than what she had before. She has an occasional hot flash, maybe twice a week. She feels great physically. She has less arthritic pain and fatigue. She's lost 32 pounds over 6 months with a significant reduction in her waist size, 5 inches just on her waist. She states that she has no mood issues. She has a better outlook on life. She has better concentration at work. Husband is a physician, and he runs a practice over on the coast. And he wasn't a big supporter of hormone therapy, but after he watched his wife go through this, he became a huge supporter of hormone therapy, and actually started sending some of his patients over here to get treated because he just didn't know enough about it. So I thought that was a great outcome of this patient. So that was exciting. She does have some acne and oily skin. This was her complaint at this visit. And she's taking all of her supplements regularly and continuing to see our fitness nutritional educator 1 time per month. So this is the third visit results. and they look great. I'm really happy with the improvement. Her estrogen came up, which was awesome. We didn't actually add any more estrogen, but we just kept improving these other areas. But now we have a testosterone that you can see is in the ideal range, but the free testosterone is a little bit above normal, which in many cases is okay. If someone's getting pellets, you'll actually see the levels above normal, but they don't have side effects. That's why I like pellets so much, hormone pellet therapy. This is a little bit on the high end, and I think that's why she's having the acne and oily skin. So I chose at this visit to reduce the DHEA. Well, you can see here, the DHEA level went up to 272. And even though the dose stayed the same, it's a cumulative over time, and it just continued to go up. Plus, as your stress goes down, your adrenals make DHEA on their own. So I continued her on DHEA, but I lowered it to 10 milligrams because I think the acne was I was thinking the acne was coming from the DHEA if it gets too high. Had her continue progesterone, continue the testosterone, but I reduced it to 6 from 8 now that we got control of her sex drive. Obviously, you don't want to stop it. Continue the Vivel or the estradiol patch. She stopped the estrogen testosterone vaginal cream. She didn't need that anymore. She was having no pain with intercourse. Vitamin D, B complex, adrenal support. Those supplements we keep our patients on long term, and continue a low glycemic eating plan and exercise plan. And then at that point that we had everything pretty much optimal, I had her come back in 6 months. We see our patients every 6 months, no matter what. We do labs before that visit. We don't go a year. We really try not to go once a year, except in very rare cases, because we want to make sure we're staying in front of any potential side effect or problem that somebody might be having. So bioidentical hormone options include, these are some of the most common options. Typical starting dose for estrogen would be 0.5 to 1 milligram. And again, we're going to work with you on this at One Peak Medical during our training program. I'll continue to work with you on identifying how to prescribe hormones, but this is just to give you an introduction to what we can use. So if it's a compounded hormone, we have all of these options here. These are all plant-based, bioidentical, customized estrogens. These are pharmaceutical estrogens that are not customized and they're not plant-based, but they are bioidentical. So estrogen patch, topical estrogen, estrogen tablets that go underneath the tongue. These can all be prescribed at any pharmacy and covered by insurance also. And then we can do combinations of hormones. We can put estrogen and estradiol together. We can combine estrogen with testosterone. So we can do some combinations also that can be customized. And then progesterone, our typical starting dose would be 50 to 200 milligrams, again, depending on the dose, depending on the problem, the side effect, and what we're trying to fix, and their age. So progesterone can be compounded pretty much any way that you want it. We can put it in a pellet, vaginal insert, creams, oral capsules, tablets. Cream would probably be the most common progesterone compounded that we write. It's wonderful because it's super good for the mood. So if you're dealing with a patient that has anxiety or depression, especially women that just don't want to be touched, that's a side effect of low progesterone. They actually do better with progesterone cream, topical cream. You rub it on anywhere in your body, anywhere actually on your body is fine. You absorb it very well through the skin. So women, a lot of times that have mood issues, I would prefer that they use a cream rather than a capsule, because the capsules or tablets don't help with the mood as much as the cream. And then if you're getting a pharmaceutical, that means you can go to any pharmacy, any commercial pharmacy. The brand name is called Prometrium. The generic name is just oral micronized progesterone or progesterone. Same thing. This one is plant-based, and it is bioidentical, and it is available at any pharmacy. Testosterone, the typical starting dose is 2 to 8 milligrams per day in the morning. Again, almost all of our, really all of our testosterone comes from a compounding pharmacy. There is no commercial availability for testosterone. We used to have a testosterone that was synthetic that you could get commercially that I didn't like anyway. It was methyl testosterone, but that's not available anymore. And oral testosterone is not a good idea for men and women. It's not good to make the first pass through the liver. It's not good for your liver. So we only use these types of testosterones now that are done at a compounding pharmacy. DHEA, the typical starting dose would be 10 to 25 milligrams. I usually use 10 milligrams for younger women when they're low on it, and 25 milligrams for menopausal women. So it's kind of the reverse of what you would think. Older women get a little bit higher dose. It comes in a capsule form. We sell it at our office. It's very inexpensive and it works excellent. You can also get DHEA compounded. I don't really recommend that because it's so inexpensive to do it over the counter as a supplement from our office, and it works great. I've never seen it not work. You can also use DHEA vaginal inserts if a person has lost sexual sensation or she's having incontinence. It's very effective for incontinence. And then we have combination hormones again. We can put different hormones together and customize them for a woman to make it more convenient, less expensive, and more effective for them. So just in review, the most important thing when you see a menopausal woman is to get a really good history of her symptoms. Don't just ask about hot flashes and how you're sleeping and how your mood is. Ask them specifically about these symptoms. This is so important, because it not only creates your chart note, but it kind of gets you in tune with your patient so you know exactly what's happening, and then you know how to treat them and you don't leave any hole unplugged. The labs that we want to order, just in review, these are the labs that we order for the initial visit. We want to see the whole picture, not just sex hormones. And then we just want to make sure that we collect a very detailed history. We want to look at their complaints, their diet, their exercise, their stress. This is not just about fixing their hormones, it's about fixing the whole body. And that mentality here at One Peak is really important, because that's how we have better outcomes. We're not just handing out hormones, we're really derailing them off of a sick path onto the happy and healthy path. Explaining the triad of hormone balance, the adrenals, the thyroid, and the ovaries, and that's what we specialize in at One Peak. We balance that triad and why it's so fundamental to get rid of all of those symptoms they came in complaining with. Giving them a couple of handouts and a couple of supplements. Start them on supplement. If they're not on vitamin D, you had their blood drawn that day, put them on some vitamin D. If they have some anxiety and depression, put them on the mood supplement. Get them going on something, because if it's going to take 2 weeks or a week for them to come back and do the test results, go over the test results with you, throw them a bone by giving them a supplement and helping them kind of get a little bit of a leg up on their symptoms. It's so fun to do that, because when they come back, they feel so much better. They're already saying, oh my gosh, I feel so much better. I slept through the night, or my mood's so much better. I have better energy during the day. You're going to use these supplements anyway, so start them on a few just to get it going. And I think they really appreciate that you've extended some help to them at their first visit. And then not forgetting that they all have to have a yearly exam. If they say, oh yeah, I had it in the last few years, it's not okay. They need to have a current exam within 6 months of starting hormone therapy. So if they haven't had it in 6 months, they need to have it. And then considering giving them a visit to the fitness nutritional expert in our office, because diet is paramount for fixing the menopausal issues. So that's the end of my lecture for menopause. I know it was a lot. It's one of those lectures you're probably going to have to watch a couple of times. It's important to get this jargon down with patients, so you're not just saying, oh, hormones are great, you don't have to worry about anything. It's important to explain the study. It's important to explain what hormones do for you long term. It's important to tell them about the controversy that's in the past. It's important to tell them about progestin, and that was the flawed part of the study. So women need to know this, and they deserve to know it. So you may need to watch this lecture a couple of times. And you'll be watching another lecture that I've done on the scientific information, a little bit deeper, a little bit more dense scientific literature on the heart, the brain, the bones, and the breasts as it pertains to long-term use of hormone replacement therapy. So thank you for listening.